This topic is ventricular septal defect. Pathophysiology. The ventricular septum is the wall that separates the right and left ventricles. A ventricular septal defect, or VSD, is a congenital defect. It's an abnormal hole or opening in the ventricular septum, causing a left to right shunt because the left ventricle has higher pressure than the right. So oxygenated blood is pushed into the right ventricle, causing increased workload for the right ventricle. This can result in right ventricular hypertrophy. Also, with more blood in the right ventricle, more blood is then pumped through the pulmonary arteries to the lungs. This may cause pulmonary hypertension and volume overload. This is important to remember as we discuss this topic more. Most VSDs close spontaneously by the age of 2 if the size of the defect is small or moderate, because the tissues around the defect grow. Clinical features. We want to keep in mind that the manifestations depend upon the size of the defect. If the child has a small defect, they may be asymptomatic and will have a loud systolic heart murmur at the left lower sternal border. Because the blood is shunting through a small hole, it's very, very turbulent, so the murmur is loud. If it is a large defect, the client may have features of congestive heart failure due to the left to right shunting of the blood and the increased workload upon the heart. The client may have poor feeding because they become tired with the energy required to feed, and this leads to poor weight gain. Slowed growth from the failure of the left ventricle and the recirculation of blood through the pulmonary system, activity intolerance with increased fatigue, respiratory distress and difficulty breathing. They may become short of breath. They'll probably have adventitious lung sounds with that excess blood being recirculated. With a large defect, they will have a soft systolic heart murmur at that left lower sternal border because the blood easily shunts through a large hole, so there's less turbulent flow and it's quieter. Complications. Increased respiratory infections due to increased blood flow to the lungs, potentially resulting in fluid congestion, which allows for bacterial growth. Pulmonary hypertension from the increased blood flow to the lungs. Dysrhythmias from changes in the cardiac structures and congestive heart failure. Eisenmenger syndrome. As seen in the image here, this may happen after years of an unrepaired VSD. A VSD begins as a left to right shunt, as seen on the left side of the image. Over time, pulmonary hypertension occurs, and the vessels to the lungs stiffen and eventually narrow, as seen in the middle image. This causes an increase in pulmonary vascular resistance. This increase in resistance causes the shunt to reverse to a right to left shunt, as seen on the right side of the image. This results in unoxygenated blood being recirculated throughout the body. This damage can become permanent and lead to other complications like stroke, kidney failure, and heart failure. Management. Small defects typically close spontaneously. For large defects, many of the medications used are the same used to treat heart failure. Diuretics to decrease congestion and fluid in the lungs. Digoxin to increase contractility and the force of each contraction of the heart. ACE inhibitors to decrease afterload to hopefully reduce the left to right shunting. A high-calorie diet. These clients have difficulty feeding, and the metabolic demands are increased due to the increased workload of the heart. A high-calorie diet will help with weight gain. Along with this, we want to encourage small, frequent feedings to avoid fatigue. Now, if the defect is too large or it's not able to be medically managed, the client may require surgical repair and closure of the defect. This can be done with heart surgery or through the groin, like with a cardiac catheterization. Nursing interventions. Prepare the client for the procedure, whether it be surgical or a cardiac catheterization. The client will be NPO, you'll have a consent signed, and preoperative medications will be administered. Initiate cardiac monitoring. Assess the infant for severe diaper rash. This may delay femoral access for cardiac catheterization and repair of the defect. The healthcare provider would not want to access the client's heart through an area with a rash. After the procedure, we will follow postoperative surgical or cardiac catheterization orders. Each procedure will require specific care during the postoperative phase, during recovery, and then prior to discharge. Client and caregiver teaching. Regular follow-up visits with the cardiologist and healthcare providers are important for preventing complications and ensuring the child is progressing as expected. We will teach the client and caregiver what to report to the healthcare provider. Cyanosis, breathing difficulties, signs of infection at the surgical or procedure site, because all of these indicate possible complications. And prevent infection. We know these clients are at an increased risk for respiratory infections, and their lungs may have been affected by the defect. So we will encourage receiving vaccinations, avoiding crowds, and proper hygiene. Good oral hygiene can help with preventing endocarditis.